Good evening and welcome. I'm Jean Johnson, a librarian at Stanford Health Library. Thank you for joining us for tonight's talk, Women's Pain Management Across Their Lifespan. It is my pleasure to introduce our speaker, Kristen MacKenzie. Dr. MacKenzie is a clinical assistant professor and co-director of the Pelvic Pain Program in the Stanford Department of Anesthesiology, Perioperative, and Pain Medicine. She's the co-director of the Stanford Women's Sexual Dysfunction Center and is part of the Stanford Pelvic Health Center for interdisciplinary multimodal care. She recently completed a Stanford Faculty Medical Humanities Fellowship focusing on the role of communication and the arts in modern medicine. Throughout the program, please enter any questions in the Q&A box at the bottom of your screen. Please remember our speaker's advice is for the general population. Do consult your own physician for specific advice. At the end of the talk, Dr. MacKenzie will answer as many questions as time allows. All right, Doctor, I'm turning it over to you.
Thank you so much for taking the time to join me tonight. This is obviously a subject that is near and dear to my heart, and I think that it's one that is widely applicable to all of our lives and the lives of our loved ones. So I hope that there's something new here for you to learn, and please feel free to put any questions in the chat, and I will try to get to them all at the end. So I do not have any disclosures. And the learning objectives for today are really to explore the history of how women's pain has been understood by the medical community, and also how we're teaching our trainees, our students, like how to understand women's health, how to understand women's pain, and why this leads to, issues or challenges down the road based on the medical curriculum that we are all being presented with. Also, to understand how women are kind of expected to have pain or discomfort at various parts of their life, which often leads to delayed treatment or undertreatment of their conditions. And I'd like to invite everyone to discuss possible solutions for patients and providers to kind of help bridge these gaps, and how the influence of social media and what we read in the newspaper, like how this influences our views on women's pain. So where to start? To start at the very beginning, in ancient Greece, as one does, the word hysteria comes from the Greek word hystera, meaning uterus. You might have heard this before, but the uterus was believed to be the source of many women's problems, including physical pain, emotional distress, and even infertility. And a common theory that was associated with hysteria was that the uterus could wander throughout the body, causing various symptoms based on its location. And there's like this magical thinking component to the wandering uterus, right? Where I think in modern days we feel like that, like this doesn't exist anymore. But I think so much of, what a woman might be experiencing when on her menstrual cycle, what different people may attribute symptoms to, even what we see now, on social media with, should you exercise during your luteal phase? There's so much mystery surrounding women's health. And a lot of it is rooted in these kind of thoughts that like this is private for women, and that there isn't research behind it, which is not true. Other earlier misconceptions came about as we grew into agricultural societies, which valued men's dominance in physically demanding field work, which became the basis for power and for wealth. Women were often relegated to household tasks, child rearing, with less control over resources or social status. And because of this, there was this idea that women's bodies were not as valuable as men's, that they were weaker, that they were less capable. And with that kind of came like, well, if you're working in the fields all day, maybe you are allowed to have pain. You have like a physical reason to have pain. But if it just happens to be the week of your menstrual cycle, or, you're pregnant for 9 months, people say, well, like women have been doing that for forever. Is that the same as like doing physical labor? Does it lead to the same outcomes? And it really perpetuated this idea that women's pain was either psychological, attention seeking, or was just not as based in true tissue damage, this like idea that we all have of pain as something that is a signal of tissue damage in our body, that perhaps that's not true. So that's where some of these ideas started developing. And then we get into the modern era where, we're no longer in agricultural societies. We have men and women in the workforce. And we have some science, right? So we think like maybe that these ideas are sort of fading into the background. But I think it's really important to realize that, this was the culture that we were brought up in, that these ideas are kind of deeply rooted in American society and also in how we um, teach, and also in how we feel like things are either life threatening or not life threatening, which is how medicine views a lot of problems. Um, and as we move into the modern era, we want to try to think like, just because things were this way for so long, do they really have to still be this way? What sort of treatments do we have, and how do we offer these? However, we are still stuck in this idea that pain is a natural part of womanhood, that it is an unavoidable part of being a woman, and that with this idea kind of comes the flip side of it, that if you are complaining about it, if you're saying, "Man, my menstrual cycle is really painful," or, "I'm going through like IVF and I mean, I can't tolerate the side effects," that other women are doing this and they're not complaining, and women have done this for years, right? So the flip is like, the problem is with you and your pain tolerance, and not necessarily with the society as a whole. Um, and there are so many ways that we view women's pain as being culturally expected. And I think one of the things that I always really like to point out is that you can't make the same slide deck for male pain. There's no like expected points necessarily where, people experience pain. People certainly go through very traumatic things. But there's no points in life where you say, yeah, like that's probably going to happen to you. Um, and for women, we see that, with the starting of monthly menstruation, which the average age of menarche in the United States is 12, that's very young, that girls are experiencing pelvic pain, breast pain, migraines, um, to name a few, right, on a monthly basis. And I think now, being a mother myself and having children, I mean, I have two boys, but I think it's kind of crazy to imagine, school age kids, or early adolescent kids, all in a classroom together, and they're all expected to perform in a similar manner. And, 1 week out of a month, girls are also expected to, care for care for sanitary products, care for themselves. If they have these things, manage them with medications, seek help. Like, I mean, these are big things for a 12-year-old, and it's a big thing to expect to do that and still achieve at a similarly high level. So just kind of food for thought here. Happens early. And then as women progress through the next few years, there's always the question of like reproductive choice. We may have seen the articles on IUD insertion pain from the New York Times in the past year, which actually was really driven by social media and women speaking out about their experiences with pain with IUD insertion, and often not being either warned about it, told about it, or offered anything for pain relief during the procedure. And this actually did lead to the CDC guidelines and ACOG, which is the American Gynecology and Obstetricians, coming out with different guidelines saying that, there needs to be shared decision making, there needs to be options given. Are these great options? I mean, do you have like a pain-free IUD insertion because of these? No, but I think that it starts the conversation, and it opens up the feeling that, you're not crazy if you have pain with this, or you have to take a few days off of work because you're having severe cramping, that can be normal and expected, and that you're supported. And I think, that's a really important conversation to start having if we want to make change. So that's already changing. the pain of having either elective or spontaneous pregnancy terminations, not comfortable, often not like completely medicated. And then for women who, go on to become pregnant, interestingly, the average first pregnancy age in the United States is 27 years old. There are 40 weeks of pregnancy. So, and with those come things like back pain, joint pain, carpal tunnel, pelvic girdle pain. So even before you even get to labor and delivery, there are 40 weeks of that happening for many women. Um, and I also kind of wanted to point out here that the IVF and trying to conceive associated pain, both emotional and physical, is quite remarkable as well. And if you guys have read or listened to the Retrievals podcast, highly recommend it. The brief summary, if you've not read it, is women that were undergoing egg retrieval were being given basically no sedation or much less because of a nurse who was diverting the sedation medication. And although the team did not know, they would tell the patient like you're experiencing what we think is like more pain than like you should be. We've given you pain medicine, and it was really attributed to them being like hysterical, emotional, faking it, even though that this was an experienced team who had seen many, many women go through egg retrieval before. And it was somehow easier to believe that they were hysterical than actually they were not getting pain medication for the procedure, which is kind of wild. And I think also, just a time when you're thinking about, you've spent a lot of money perhaps on IVF, you've invested a lot of time, and, there's a certain window in which you can do egg retrieval. And so it's a really, really high stakes environment, and you're kind of given the option of, well, you can stop and, if you're in pain, that's it. You just don't get your eggs. And women are kind of expected to, if you want to be pregnant, be quiet and get it done, right? And so that was a really tough situation, and I think really just speaks to a lot of stress that is placed on women and a lot of preconceived notions of how much pain they should be or could potentially experience for the goal of having a child. So some really big thoughts there. Then when you go on to labor and delivery, probably one of the worst pains for unmedicated birth, like that's known, right? So then this is not small amounts of pain, but women do this all the time, some often unmedicated. The average labor is 12 to 18 hours for a first delivery. 80 to 90% of women experience vaginal tearing. This doesn't even have on here the rates of C-sections, which is really a major abdominal surgery that requires major recovery afterwards when women are also caring for an infant. And then, pain associated with breastfeeding, mastitis, raw nipples, right? I mean, there's so much, I think, for women who have been through it. It's just, it's something that you are expected to get through, and you be, happy that you have a family, which I mean is so, valuable, but is also like a time that we want to say it's okay to have pain. It's okay to ask for help. And, being seen 6 weeks after giving birth, which is a standard for vaginal delivery in the United States, still is really a long time to kind of wonder about things in the interim. Then women often go on to have caregiving roles, either for children or for elderly parents. I like this picture a lot in the middle because it makes my back hurt thinking about it. It's not a super ergonomic setup there. There's sleep disturbance, there's increased stress, all things that we know, will increase pain levels as well. And then following the years kind of caregiving, often being, the family coordinator role, which often falls on women. Then there's the progression into menopause and perimenopause, where even, decades before going into menopause, women might start to experience some of the perimenopausal symptoms, which I think is starting to get a little bit more traction in social media, which is great. But even then, women report like, you've hot flashes and you're being worked up for cancer, right? And then they're like, oh no, wait, it's just menopause. But then like what's the answer? Like, how do we help these women? And during that time, you may have hot flashes, joint pain, pain with sexual intercourse, sleep disturbance, and many other things that if you have other baseline pain issues could absolutely exacerbate that pain as well. And then lastly, as you kind of move into the golden years, post-menopausal, we know that women have decreased bone density due to declining estrogen, that they are at a higher risk of developing a fracture, which can absolutely be like life-changing for someone who was previously very active and social to say like have a femoral fracture and maybe not walk again or have to go through, a hip surgery and a large rehabilitation, which can be both socially isolating as well as very physically demanding. Osteoarthritis, as women live longer, often than their partners, you'll find that they may be living longer with chronic health conditions, with more emotional isolation, and may be suffering from more wear and tear of the joints and pain associated with that. But yet there's not really, I think, a lot of solutions being offered. And so often women have also felt that throughout the years, no one's been offering to treat or address their pain or ask them about it, and that these were always things that they were kind of told, like this is part of being a woman, it's part of going through life. And I think that we often see our older patients are not always seeking care, and they say this is just how it's supposed to be for me, which is another kind of narrative that we want to change around what options are available later in life and how to remain active so that you can remain like socially engaged, which we know is so protective for living a healthy, engaged life. So, what is the end result of this? The way that we have addressed the inevitability of women's pain, it ultimately prevents women from seeking appropriate medical care when they need to, leads to fear of dismissal or being told that they're overreacting. Women are also more likely to be prescribed anti anxiety medications when they come to the hospital with pain, versus men are more likely to be given tests to rule out organic conditions. And we know that women will wait longer in emergency departments before receiving pain relief compared to men. So, in addition to the historical and cultural expectations that we've just discussed about women's pain, there are other biological and social factors that change how women detect and experience pain. And I think that it's important to kind of go over this because women are biologically and hormonally different than men, and there are changes in how we experience pain that are worth discussing as well. So, first, women detect pain at lower thresholds, and I think sometimes like my female patients don't like hearing this, right? You're like, "No, like I have a really high pain tolerance, like I can tolerate a lot of pain." And this is nothing to do with how much you can tolerate. It has to do with the threshold at which you'll say that's painful. And for women, it is less than men. And why is that? I think there's a few different reasons we can get into. Um, but first, kind of just going down the bullet points, females display greater sensitivity to painful pressure and thermal stimuli than male individuals. And that sex differences in pain sensitivity tend to appear around the time of puberty, which indicates that hormones may play a role. Testosterone seems to be protective or anti-nociceptive versus estrogen, and that even how we detect pain may change with different timing in our menstrual cycle, which is really interesting to think about. Um, and I always kind of like to offer to my patients, like, why might it have been advantageous to detect pain at lower thresholds. And I think especially if you're, historically, right, like back in the day when we were all cave people, we were maybe the ones that were caring for children, caring for a family, and being able to sense that something is wrong and also get to shelter quickly could be an advantageous and evolutionarily important thing to do. Additionally, this ability to kind of detect, like we think about pain as physical pain, but also, we know that many of the brain pathways in pain are shared between emotional pain and physical pain. And I think, women playing a very social role in the community, being able to see, like on a friend's face or in their body language, that that person is sad or that they are suffering. Those types of emotional discriminations are very similar to physical pain discriminations. And so, again, it allows women to be empathetic, to make those social connections, which in turn allows community and safety in community. So, I just like to point out that it's not a bad thing. It just means that we are going to feel things and perceive them as pain at a level that perhaps men do not. Um, the next big point is that experiencing pain leads to more pain. And I like to tell my patients, kind of like Steph Curry shooting that 3-pointer, right? If you practice something, if you're the concert pianist and you practice all the time, it becomes like muscle memory, it becomes nerve memory. And there is this component where if your body is experiencing pain for whatever reason, it's going to become really good at having pain. And it's nothing that people are doing to themselves. It's just like how neurobiology works. So when we look at women that were in the community who had painful periods, and this was self-reported painful periods, then they looked at them over a 10-year follow-up. And they said, do they develop other chronic pains? So pain that's persisting despite like the thought that they should have healed in that time frame, so greater than 3 months, and multi-site pain. That painful periods actually independently increase the risk of going on to develop other chronic multi-site pain, the 41% greater risk. So in more body areas and greater pain. Women are also more likely to experience trauma and sensitizing events, which are ways that sensitize the nervous system to say that there's danger. And pain is ultimately our alarm system. So it tells us, like, watch out. Like, when we're young kids and we touch a hot stove and we learn if you touch the hot stove, you get a burn, you need to move your hand. That's our alarm system. And so pain is supposed to be there to teach us something instructive and get our alarm system going. But I also tell my patients, like, humans are not that, we like to think we're really evolved. We're not that evolved. We use very similar neurotransmitters. Our cortisol, our adrenaline, our fight or flight system is very similar to our pain system. And so for people who have experienced significant trauma, which could be interpersonal trauma, it could be being in a car accident or being in a domestic abuse situation, or having scarcity as a child, or no stable housing situation. All of these things rev up our fight or flight system, which then makes us more sensitive to pain as well. And I liked this study a lot. I mainly do pelvic pain. And so irritable bowel syndrome falls in the gastroenterology realm, but has a very high overlay with our patients as well. And they found that IBS patients were much more likely to have had these types of sensitizing events than patients who did not have IBS. And these significant differences were mainly observed in women. And then, even though adverse life events and psychological variables are related, that adverse life events actually have an independent association with IBS. So it's not that being, you're depressed, so you have IBS. It's that you've had these events in the past, and those can definitely drive who goes on to develop IBS. And that can just be because the nervous system is more likely to perceive maybe normal bowel movement as painful, as spasm. And part of that comes from your body trying to protect you and sound the danger alarm earlier. And lastly, women with IBS were more likely to report a history of adverse childhood experiences than men with IBS. So, unfortunately, a lot of these traumatic experiences are more likely to happen to women, and then more likely to sensitize them to go on to develop some of these chronic pain conditions. So, the way that we teach pain in medical school is very similar to what we just talked about. Right? You touch a hot stove, you have some tissue damage, you burned yourself, your body goes to work healing it, and within a few weeks, you're healed. You're not in pain anymore. The pain has resolved, the scar is there, you've learned a lesson. You're not going to touch hot stoves unless you're my children, in which case, you'll need that lesson taught to you several times. But in any case, it's there to be instructive. And this is how medical students, when we ask them, okay, the patient presents with abdominal pain. What is it? They think about everything in the abdomen. They're like, okay, is it the liver? Is it the spleen? Is it the bowel? Is it the aorta? Is it the lung? Right? So they're going to create a list of all the things that can possibly present with abdominal pain. They're going to make that list, and they're going to put it in order of like most likely to kill you, the can't miss diagnosis versus the most likely diagnosis. And then they come and they present it. And that's an A+ medical student. But I think that unfortunately, it really underscores to them that there always needs to be a scan, a sign, a physical like sign of tissue damage that explains the pain. And if they can't find that, then they feel like it's not true. It must be in your head. It must be somewhere else, right? Um, which can really lead to the sense of dismissal when really, I mean, they're trying to find something that they can, one, intervene on, and two, that will save someone's life, which is sort of what we want our doctors to do. But we're really missing a way of talking to them about, well, what happens if you've gone through this list and you've done your due diligence and you don't have these things. So pain is defined as an unpleasant sensory and emotional experience associated with or resembling actual or potential tissue damage. But we know that women are also more likely to have what we call nosoplastic pain, which is different than nociceptive pain. Nociceptive pain is what we traditionally think of. You burn your finger, a sensory nerve ending in your finger transmits that to your spinal cord, goes to your brain. Your brain creates a representation of that pain. Um, but nosoplastic pain is actually a mechanistic term that's used to describe pain that occurs despite the absence of tissue damage, which is kind of crazy. But there's this activation of shared brain pathways, which are very complex, as you can see from this Kaplan paper model. There's stuff that's happening in the brain, there's stuff that's happening in the spinal cord, there's this regulation of information going up and the brain control going down. That is way beyond the scope of this talk, but what it essentially means is that the mechanisms of nociceptive and nosoplastic pain overlap and the brain can't tell the difference, which is really wild and leads to the intractability of chronic pain because your brain is getting the same signals, and to that it's the same, right? But there's this dysregulation and information coming up and information going down, so that even though we think that in many times the initial injury has healed and we can no longer find evidence of it, that people go on to continue to have pain in that area. And so that's called nosoplastic pain. This is from the same paper, this Kaplan and al. Paper. And they say, although the exact cause or causes of nosoplastic pain remain unknown, female sex, early life stressors, trauma, poor sleep, heightened somatic awareness, and physical inactivity all independently increase the risk for nosoplastic pain. So it's a lot of different things. And I think on some level, we all know this in our heart of hearts. And again, I think it's hard for our patients who are really coming in wanting a definitive diagnosis and treatment. But I always tell my patients, like, I mean, I know that if I've had a long day in clinic, I have a very full inbox that I haven't got into. I'm sitting on 101 in traffic, and I walk through the door and my kids are like, Mom, what's for dinner? Right? If I step on one of their Legos, it's going to really hurt. It's going to hurt in a way that it would not normally hurt to step on a Lego, which hurts, but not in the same way as when you are um, exhausted, when you have, been dealing with high levels of stress all day. So we all kind of know this about ourselves. And I think that like recognizing it in a chronic space, and especially for females, really helps understand like why we see so many more chronic and overlapping pain conditions in women. Okay, so these are all headlines from the New York Times over the past few years. You may have read some of these articles yourself. And I am really torn how I feel about them. I think as a physician, I mean, they make me feel kind of sad, and they make me feel like, doctors are not doing a good job, even though many doctors that I know are deeply caring and deeply smart individuals, right? But all of this speaks to women feeling abandoned by their doctors and not heard. And it makes me wonder how can we do that, right? Like how can deeply caring doctors make patients feel so ostracized, and are we not doing our job? Are there things that we could be offering that we're not offering? And I think it does drive somewhat of a wedge, right? Because there is this distrust of the medical system, and then doctors then start to distrust the patients. So they're like, oh, they want me to do something that I can't do or I can't fix. And I think we want to have a conversation. We want to make these things not taboo, but also, how do we instead of just saying like things are not good, we know things are not good, how can we fix it? And that's a really hard answer, and one that I wish I was giving in this talk. So I send apologies if you've been waiting for the answer, because I unfortunately don't have it. But I think there's some things that we can kind of brainstorm where we need to go with this to make real change in the medical system. So, quick recap: women's pain experience is shaped by historical, biological, social, emotional, psychological factors. And like doctors can't change a lot of that. Like there's a lot there that I wish I could change, but we're also products of the system, and we have to recognize like where the system has biased us in order to offer appropriate medical care. And one of the things that I think is so important is to offer appropriate diagnostic workup when it's needed. And if it's not needed, to explain to the patient why it's not needed. Even if a patient is coming to me with chronic bladder pain for years and years, if they are having a really rough day and they're like, I just really feel like I have a urinary tract infection, I just cannot move on from this until I know, like get the urinary get the urinary sample, like run it, see, and I think it's like when we look at like medical spending and all these things, it's like, what if there is a UTI and the patient then becomes septic and we've dismissed it? Like that's not helpful. And I think a lot of times women are very in tune with their body, and they'll even tell you, "No, I know it's not that. This is my chronic problem. I know it's my chronic problem." But I think even taking it seriously, thinking about it, making sure we're not missing anything is so important. And if you're like, I don't think you need an MRI. I don't think the MRI is going to show what we're worried about. Like, this is what I'm worried about. I don't think the MRI is going to show it. Being able to explain, I would say most of my patients are like, oh, like I went to go see three doctors and they all told me I didn't need an MRI, but I thought I had cancer, and now I understand that that wouldn't show me that. And it's like, how can you get over chronic pain when you feel like there's a misdiagnosis or that you are in danger? Because it's a danger signal. So we need to be able to, one, practice appropriate medicine, offer diagnostic workups, take people seriously. But if it's something that isn't going to help us, be good at explaining why it wouldn't help us, and what they may want to do instead, or when they would need to come back to care. Which takes a lot longer than saying you don't need that and walking out of the door. But we need to be able to help our trainees navigate these sort of situations, so that people don't bounce from doctor to doctor, right? Trying to find someone to explain to them or make them feel heard, because that ultimately leads to overuse of the medical system. And with that goes hand in hand that pain is inherently a subjective experience. Like, I could burn my hand, and, my best friend could burn her hand, and we both might feel like very differently about it, which could vary evidently based on our menstrual cycle or our amounts of stress or our past histories or just our DNA. And so there's a lot there where I don't know what anyone else is feeling. And what we can do is say, wow, it really looks like you're hurting. And that is never the wrong answer to give. This is a quote from again, American College of Obstetrics Gynecology. They put out a practice bulletin in 2020. And I really like this because I think it speaks to exactly what terrifies some doctors about chronic female pain, is that it's hard, right? That a chronic pelvic pain patient's pain may not improve until her endometriosis is treated, reactive pelvic floor myalgia is addressed, central sensitization is controlled with neuromodulator treatment, and depression is in remission. I mean, those are like big asks, right? There's a lot of things there that involve, I hear a pelvic floor PT, a gynecologist, a pain physician or a pain psychologist, and maybe even a psychiatrist, all working together over time to bring someone's chronic pain into remission. So these are not easy things to do. And I tell people, if it was easy, someone else would have already done it, right? So how do we move forward, given that everything in the system kind of seems to be, working against us at times? So this is a fantastic paper, that was published in Pain last year. And they took some patients who went through pain psychology for their chronic pelvic pain, and then they asked the people who got better, like what was helpful for you, like what parts of this really resonated with you, and what do you wish you had been told earlier, like what do you wish people knew. um, and so they pulled out these four themes, right? Which is that, a sensitized nervous system can lead to overprotective pain, which validates that their pain is real, that is their experience, and that their nervous system is sending them the problem. And I think sometimes when we look and look and look in an organ system and we're like, well, your uterus looks okay and your bladder looks okay. I mean, that doesn't help people. But saying your nervous system is like having a seizure in your pelvis, it is overcommunicative, there is too much electricity, like that is valuable, and that gives people an understanding of why they're having that pain. So very helpful to have that neuroscience education. Second theme is that, like, pain does not always mean damage. It can, and often pain does start with some damage, but pain that persists despite, no medical cause or ongoing tissue damage being found, can reassure people that they're not going to hurt themselves more, that their condition is not getting worse, and that they can move on without the fear of hurting themselves, that they're not ignoring an important signal of danger in their body. And that the third theme is that they really have some autonomy over their pain, like how they see, think, feel, how they frame their pain, can make it better or worse. And I think for a lot of people, I mean, this is like torture, right? That they didn't put their hand on a hot stove. And as far as they can tell, they're not doing anything to cause their pain. Um, and that's a lot of like loss of autonomy, loss of control. We like humans like to have control over our bodies and see a cause and effect relationship. And I think being able to change your thought process around it can be very powerful for lots of patients. And lastly, that they are empowered to change their pain, and it might be really slow, and it might be a combination of things. It might be physical therapy, it might be pain psychology, it might be nerve blocks, it might be primary treatments with, say, like a gynecologist or a gastroenterologist. Um, but it might be medications, but that there are many paths forward to reprogramming the system and teaching your body that it is safe. Okay. Um, and then lastly, just some thoughts on like how do we move forward in this? Because so much of this I think is rooted right in the past. And like when my patients arrive in my clinic and we say it's like not the first stop on the train, right? They've usually seen their primary and several specialists, and they feel really like, no one has seen them as a whole person. And now they've collected all these other experiences, which will change their pain forever going forward, like distrust of the medical system. It's like, how do we catch them earlier? Like, and so some of that is patient education, but some of that is physician education. I think actually a lot of it is physician education. So we want to teach medical history. Just because pain was expected, decades and decades ago, when we said, yeah, you're going to have pain with your periods. I mean, now we should be talking to patients about IUDs or continuous birth control, or if they don't want hormonal options, are they a candidate, for NSAIDs with their periods, or even other neuromodulator treatments to prevent chronic pain, like assistance with letters for school, things that keep them active, engaged. These are things that we know keep people healthy. So we want to uh, say this is where things were before, but maybe this is where things are going. And there are new treatments all the time, and medicine is changing all the time. And part of this is including women in research. I think like the COVID vaccine development when I was pregnant with my second child, that was COVID, and I was like, I mean, I'm getting the vaccine, but it wasn't tested in pregnant women. So there's really no data. It was a complete black box. And for many drugs, we go off of male dosing studies for even like antidepressant drugs, right? And maybe we should be dosing way lower for women. And so even dose finding studies really should be recruiting for women as well. Um, and then thinking about, pain management as part of like a lifelong process. We know that experiencing pain leads to more pain. We don't want people to experience high levels of pain. It's not good for the nervous system, even if, everyone has experienced that with pregnancy before at some point. It's like, why do you need to? Like, why does your back need to hurt when you're pregnant, right? And if we have something for that, like, let's offer it. And even if it's not a great answer, saying, man, like that's really hard. Have you seen this PT? Have you tried this SI joint belt? Have you tried this lidocaine patch? Like, just offering options and legitimizing women really, really appreciate. Um, we also, want to educate our medical students and explain that maybe they've run down the list of all the things that can kill you and are likely to cause pain. And if we've scanned and we've looked and we've ruled those out, like starting to adopt this paradigm of talking to people early about their nerves, their muscles, these other pain generators that, can lead to chronic pain in the spinal cord, in the brain, that these aren't, bad words. These aren't things that we can't treat. These are things that we can treat, and pain can live many, many different places that aren't just in the organ system where the patient is pointing. So I think that is very important as well. And lastly, just wanted to underscore that advocacy is really important. both, from medical providers to other medical providers and trainees, but also for teaching women how to talk, at medical appointments. Like, I feel like this is something we should be teaching in high school, like you can go through your economics class and then you can also teach like basic like medical, like how to advocate for yourself, how to make a list, how to prioritize your list, and how to be strong, because a lot of people will defer, or they're scared to ask. They don't bring a friend. They don't say what they're worried about, and all this is kind of a cultural construct that we can change by teaching patients, that it's okay to ask. Okay, and those are my references. So that is the end. Thank you guys very much.
Thank you, doctor, for that important information. I do have a couple of questions. Um, Someone asked, can you please speak to the use of NSAIDs for pain of menstruation?
Yeah. So NSAIDs are nonsteroidal anti-inflammatory drugs. They are the mainstay of therapy for painful periods. These are the first line agents recommended, again, by obstetricians and gynecologists. And the reason for this is that they work by decreasing prostaglandin synthesis, which is what will ultimately reduce uterine contractions and pain. So they're really, really good drugs for pain reduction during the menstrual cycle. Multiple studies have shown that they're more effective than a placebo or acetaminophen or conservative therapy for menstrual pain relief. But it doesn't really matter which NSAID you take, they're all kind of the same. And I usually tell my patients, take them starting 1 to 2 days before the start of your cycle. You can continue them through like the first few days, maybe the first 2 to 3 days of your period, which is when the uterine contractions are going to be the strongest.
Thank you. Someone else asked, what does Stanford see as the future of pain management for complex regional pain syndrome, particularly in women, given all that you've said about minimizing pain?
Yeah. No, I love that question. I think for those who don't know, complex regional pain syndrome often is a due to a nerve injury, but sometimes it's not a recognizable nerve injury, which often leads, I would say, we know that women experience higher baseline rates of kind of dismissal and not being taken seriously, and then ultimately later to care. And I think many patients, male and female, with complex regional pain syndrome also experience this kind of dismissal because it is such a rare condition. And certainly it has to be more in female as well. Um, in terms of what the future is for it, I think we're coming up with interesting, we have a great group here that specializes in that. It's not my specialty, but, innovation around that. And a lot of data shows that treating people earlier rather than letting this progress to later stages is really important. So again, I think it's honestly raising awareness and catching it earlier, getting people into pain clinics that are able to treat this earlier is going to lead to better outcomes. But I wish I had a specific treatment for women for this.
I did want to mention we had a previous speaker specifically from that clinic, I guess, about understanding complex regional pain. That was a few weeks ago. The lecture is posted on our website at Stanford Health Library. So I encourage the person who asked the question to see that if they haven't already. I did have a question about, are there any free courses about pain management? Do you know of any kind of resource? I know we have some books about chronic pain here, self-management, that kind of thing. Do you know of any courses like for free or anything like that?
Yeah, it's a great question. And I think that's awesome that you guys have a list of books. And I'd really,
Mhm.
if you're able to post that, I think that would be great.
think you froze a little bit.
Oh no, am I back?
Yeah.
Okay, I'm so sorry. Through our clinic, we offer a free empowered relief class. So for anyone who has a referral to Stanford Pain, we usually recommend that they do this 2-hour mind body class, which has been very popular. And our pain psychologists also run some other CBT oriented classes as well for free. But again, those kind of come as a referral through our clinic. For like stuff that's just out there, I like Curable, which is an app, which kind of like a mindfulness app that you can download to your phone, be very helpful. There's a website called tamethebeast.org, which talks about chronic pain and understanding like different ways that we can influence our own chronic pain. And lastly, I'd throw out there that Minda Health is a pain psychology service that connects you with a mental health provider around chronic pain, and it's covered. Most commercial insurances only pay like a $10 to $15 copay. So not sponsored content, but and Medicare covers it, and if you
Yeah.
have secondary, they cover the copay. So Minda Health is great too.
Well, thank you again. And I want to thank our audience too for these great questions. If you'd like any additional information on resources, or like I mentioned, or any other kind of health issue, please contact Stanford Health Library, and we hope you'll join us for our next lecture. Thank you.